Can you see me by any chance?
No, sir, your video is not.
No, no, not. I meant like the invite.
So can you switch on your video?
Yeah.
Yeah. Okay, I'll start. So, hi
Am I
everyone.
am I not visible in the lobby?
So you are visible now.
No, no. In the lobby, aren't I there?
No, sir, you're not there.
Is it so?
Okay, I'll quickly start the
Yeah,
webinar. All
yeah.
right, so hi everyone. I hope you're doing great and are having a wonderful day. So, before I jump in today's topic, let me introduce Positivity. So, Positivity is a Singapore headquartered mental health organization. So, we are committed to making quality mental health care accessible and more affordable for everyone. And our aim is to connect individuals with the right experts in our on our platform while creating awareness on different topics. And speaking of topics, we have a very interesting topic today, and that is on neurobiology of trauma, what happens in the brain and body. Now, that's a very interesting topic today, and it is presented by our very own neuropsychologist, which is Mr. Darshan Shetty. And he is our in house neuropsychologist at Positivity, listed at our platform. And a little bit about the topic. So, trauma doesn't just affect our emotion, it also impacts our body, our brain, and, its function. So, experiences of trauma can influence other areas of our brain as well and our body. So, it is important that we know what each area is responsible for and understanding the biology of it as well and recognize why people respond in a certain way or during those difficult experiences. So without any further ado, let me hand over to Mr. Darshan, and he is also taking sessions and helps in areas such as like ADHD, addiction, substance abuse, and neurodivergence management as well. So his expertise will really help us. So without any further ado, over to you, sir.
All right. Thank you, Shreya. Thank you, everybody, for having me here. And my name is Darshan Shetty. I'm from Bangalore. I'm a consultant neuropsychologist. I primarily work with neurological disorders. I have around 5 years of working experience, and I mainly work with trauma. It could be neurological rehabilitation, and so on. Now, since we know, we've read a lot about trauma. We have been there. We have seen many people going through trauma, and we know what trauma is and how it has been revolving around us and how trauma has evolved with us as well. One of the few things that not everybody would like to talk about is what they go through during these episodes of trauma and what exactly is going on with them in such cases. So today's topic is going to be on the neurobiology of trauma. Trauma is on how it could impact the mind, the body, and also what could be done regarding the same. So now, you know, neurobiology, since there are two things that is going on, neurology plus biology, where we'll be looking at trauma from a very biological perspective. And since it is a very complicated topic as well, I would like everyone to be a bit more, conservative on regarding this. So to start, we just can't say, okay, trauma is not like a simply an emotional experience that someone just goes through, right? Or we just can't say, okay, it is a psychological reaction to a particular thing. Right? But there's a lot of other things that is happening at the same time. There's a lot of neurological and biological aspects that are there that also does happen at the same time. Now, but even that can alter the entire cytoarchitecture of the brain, the chemistry of the brain, or the connectivity, the functioning of the entire central nervous system and the other of the brain as well. So, as we know, there are good amount of research that has been conducted, that are still ongoing, that have always been very fascinating to see. Over the last few, years, we have seen so many advances in the field of psychology, neuroscience, neurology, and the understanding of what is trauma and the kind of, research that is going into all these things has just been fascinating. And especially when it comes to neuroimaging and psychophysiology and psychiatry also, we have got good amount of improvements, and our understanding of how traumatic experiences influence the human brain. So now we'll start going into the topic. We'll be able to understand how trauma affects the emotional processing. It could be the memory formation. It could be attention problems, or how it affects attention part, like executive functioning, stress regulation. It could be immune system, the entire functioning of the immune system, and also physical health at a very long term stage, if you may. So we'll be outlining the biological aspects of trauma. Now we'll also be going into the major brain structures of brain regions and the neural pathways involved in stress and the fear responses that we have. Uh, we'll be going into different brain regions such as amygdala, hippocampus, and prefrontal cortex. And we'll also be discussing the role of the autonomic nervous system, right? The hypothalamic pituitary adrenal axis, we called it as the HPA axis. It's a very important aspect. So we'll be going through that as well. Also, like, parallelly, we'll also be examining how and talking about how traumatic experiences during childhood can also be can disrupt normal brain development also, that also can or is leading to long-term imbalances, long-term emotional and cognitive consequences also. And not to forget, we'll also be discussing about the neurobiology of the not only trauma but beyond trauma. It could be spirituality, or it could be more towards the metaphysical world, and how we understand it and what we think about it, and about the philosophy as well, and how trauma contributes to modern trauma informed care, and also therapeutic interventions such as therapy, or neuro rehabilitation techniques such as cognitive rehabilitation or cognitive retraining for the matter. So I will start presenting. I hope everybody can see the screen.
No, your screen is not visible.
Is it so?
Yeah.
1 second. Am I visible now?
So you're
Shreya?
visible, but your screen is not visible.
Okay. How about now?
Yes, sir, it's visible now.
Super. All right. So we will be starting with the slides, and we'll just go directly into all the topics. Now, the main aspect, the neurobiology of trauma. So one thing that we have to understand and learn more about is what we define trauma as. And trauma there are a lot of changes that happens when a person is undergoing trauma. It could be brain structure changes, the nervous system regulation, and hormonal production, emotional regulations, and dysregulations as well, and the physical health. Now the brain becomes oriented towards survival rather than growth or connection, right? So trauma responses are adaptive survival mechanisms, is what we understand. So, what is trauma? Trauma occurs when an experience overwhelms a nervous system's capacity to process the stress. The body interprets trauma as a threat to survival, activating neurological defense systems. Over time, these systems can be chronically activated as well, fundamentally changing how a person thinks, feels, and remembers and behaves. So now, what we are able to understand from this particular aspect is that though there is when trauma has been inflicted upon, now there's good amount of experience that is overwhelming the entire central nervous system, and for the body and for the entire CNS, it is something very new, and the body is very alarmed. The entire nervous system is very alarmed, and the body doesn't know what to do. The brain doesn't understand what is this, and that is why the brain just goes into panic mode, right? Because this is something new. Now, at that point of time, there's a lot of things that's taking place. It could be when we talk about hippocampus or the amygdala. Now, the amygdala, which I will get to later, amygdala is the primary brain region for the emotional regulation. Now, that is one of the important aspects that we'll be dealing with, that and hippocampus is a brain region wherein memories are stored, formed, and retrieved, and this is one of the also one of the most important aspects of trauma, because hippocampus and amygdala, they have a bidirectional connectivity wherein they both are interconnected together, and whatever and whichever information they are sharing and retrieving, they are doing it real time. So that is one of the primary mechanisms of how trauma has been understood, stored, and retrieved during certain situations. Now, if I were to define trauma into a more broader way, we can say that trauma can be defined as more of an emotional, psychological, and a physiological response to an event or a series of events that are experienced as as very distressing, displeasing, and threatening and to the body. And at this time, everything can become very overwhelming, almost everything, right? Now because the suddenly the brain is under attack and the entire system is under attack, and the body just doesn't know what to do, where to go, and how to go about it. So now these certain events exceed a person's ability to kind of cope and process different experiences. That is what we see. Now, how does it play a role in neuroscience, or does it have any role to play? I would say yes. It starts embedding into the neural pathways. There's hormonal systems that we can see, muscular tension, and atrophy is also one of the things that we have been seeing from the last. The latest research is also showing us evidence regarding the same, and immune functioning and emotional processing systems that are there. So the thing is, importantly, what I have to point out is that trauma is definitely going to be subjective. One or a couple of people may experience the same event differently, depending on factors such as personality. It could be developmental stages of whatever they've gone through, social support, genetics, and the experiences in their life that they've had previously, and the neurobiological vulnerability. So, and that is why, trauma survivors experience panic attacks, they have high loads of episodes of hypervigilance, emotional numbness, chronic fatigue, digestive issues, memory problems, and relationship difficulties. So that the aspect that I want to focus on right now is going to be the hypervigilance. Once when a person is being inflicted on trauma, or when like a person is experiencing trauma, or once it has already taken place, now there's override of the prefrontal cortex, which I'll get to later. So now this is a particular brain region which is responsible for the executive functioning, that is the decision making part of the brain. So at that point of time, it is all connected. It is all interconnected. Now the prefrontal cortex is connected to the hippocampus, that has to deal with the memory, and the amygdala, which has to deal with the emotional part. So when there is good amount of stress, and it could be about, you're always wondering or worried about what could happen next. You're always in the constant state of fear and panic. So because of which we can see hypervigilance. The hypervigilance can be termed as, I mean, it is in the name itself, hypervigilance. Being hyperly vigilant about your surroundings, or your immediate surroundings. It could be people, it could be things, or it could be anything that you have been dealt with recently. So because of that, there is good level of stress that is also taking place in the body, because chronic hypervigilance leads to something called as allostatic overload. Now, allostatic overload is the wear and tear of neurons, and that is not okay. On a long-term basis, that is definitely not okay. So we start becoming numb, right? When we start understanding emotional behaviors or emotional availability and unavailability of ourselves, we suddenly become numb. At one point of time, we might not be able to understand, or we might not be able to even experience things properly the way it should be experienced. And chronic fatigue is also one of the factors that we can see, because of the hypervigilance, or because of the HPA axis, or because of the alert system that has always been alert in our body. It is always there. And because of this chronic stress, we can see fatigue. We are naturally stressed out. Our brain just doesn't want to do anything. We just want to sleep, or we just would want to go into hiding at one point of time. It does feel like that sometimes. And there are situations where we might get digestive issues because of the anxiety that is creeping up, and memory problems, which I will get to later, and relationship difficulties. Definitely maintaining good relationships with it could be our subordinates, it could be our immediate family members, our partners, husbands and wives, anybody for that matter. It becomes a difficult part. So we'll move on to the next slide. So acute versus chronic trauma. Now, there are different forms of trauma. It is just not saying, okay, trauma is one singular thing and there are so many things inside that it could be used as a umbrella term. No, it is not just that. But from a neurobiological perspective, there is a lot of things happening when it comes to acute and chronic trauma. Now, before I get into that, like, I would also want to point out that during a traumatic episode, the entire nervous system, the central nervous system, definitely it would go into an override. But also, it is also slipping into the survival. Now, it is also chronically there, right? It is always shifting into, okay, survival mode, and then being at a very calm paced mode, and it is constantly going up and down, up and down. Now, that leads to the sympathetic nervous system being very stressed. Now, that leads to the hormonal disruption. There are many hormones which are definitely affected by this entire dysregulation. So that leads to something called as cortisol and adrenaline. Now, while these responses are adaptive in the immediate danger, prolonged exposure to these things, or repeated activation of these central nervous system processes, or the chronic or the acute trauma responses, now that may give long-term dysregulations of the neural system, which is not good. That is why we will be talking about acute and chronic trauma. Now, chronic and acute, I'm pretty sure everybody can make out the difference between acute and chronic. So acute trauma results from a single or a discrete event. That could be a car accident or an assault. Like, now we are seeing a lot of rage uh, outside on the streets. It could be just for an accident, or two people fighting. Now the brain amounts a rapid, intense stress response from it, right? The brain is alarmed and you just don't know what to do, and the brain just goes into fight or flight mode, and it is very, hyperactive, right? So in most people, this particular event usually resolves within a few hours, days, or it could be weeks also. But chronic chronic or more complicated kind of trauma involves or has repeated exposure. It could be war, it could be childhood abuse, it could be domestic violence, it could be sexual abuse, and many things. So now this prolonged exposure to this, the chronic uh, uh, aspect of of trauma, is definitely going to worsen the entire nervous system and the processes, and is going to worsen the stress response also. So now that activates the stress circuits that we have, that we will be talking about, is the HPA axis dysregulation, and it can also lead to the hippocampal atrophy. Atrophy in the sense we call inflammation, right? There's got a amount of inflammation in the hippocampus region, and the amygdala being a dysregulated region in itself, and also HPA axis, which will come later. And there's a lot of other inflammation that is happening, taking place throughout the body. Now, complex trauma, it's profoundly is disrupting the self-regulation. It is affecting the identity, attachment, or forming attachments with other people, and other problems of uh, PTSD. Now, why is it such a big deal? Why is acute or chronic trauma such a big deal to the body? Now, hippocampal atrophy is something that is not okay for anybody that is going through trauma, because the hippocampus is being inflamed, and the inflammation of hippocampus is not okay. The short-term memory, the long-term memory, and the working memory, all of these things are going to be disrupted. So there's going to be a good amount of forgetfulness, and the amygdala also being there, which is working bi-directionally also, will have the same issues. Not inflammation, I would say, but having to deal with emotions from time to time, and other processes such as override and being hyperactive and hypoactive at the same time. Now, the hypothalamic pituitary adrenal gland axis, the way it beautifully works is that when the hypothalamus gets to know that, okay, there's a stress, a response that is coming from the brain or the central nervous system, it releases something called as ADC, adrenocorticotropin release factor. So this particular chemical is being released by the hypothalamus, then essentially going to the pituitary gland, and it signals the pituitary gland to say, okay, look, something is not okay. I think we should do something regarding this. And then pituitary gland releases another chemical, and that essentially leads to the adrenal gland. Now, then the adrenal gland would essentially release something called as cortisol. I'm sure everybody knows what cortisol is. So chronic release of cortisol is definitely not okay for the brain and for the body and for ourselves at a long-term basis, because it is affecting us at a neuronal and cellular level, and that is very bad. When we think about it, many people just ignore this particular aspect. They feel, it is not such a big deal, okay, we'll just get over it. But there's a lot of things that is actually happening than we actually realize, right? So when we talk about the prevalence and the significance of trauma, now it is very common. I'm sure trauma is probably the most used term out there. Now, epidemiological studies, especially the ASN study, now they have indicated that 70% of adults worldwide have experienced at least one traumatic event, at least one traumatic or two events, and approximately 20% of those have developed PTSD. Now, developing PTSD is not something good, and it's something that is definitely not encouraged. But trauma is not just a psychiatric issue but it is also a major public health concern that is linked to many other comorbid conditions. Now, people just think, okay, someone is going through trauma or has been inflicted upon trauma, and they feel that, okay, there's no other comorbidity or comorbid condition that can come in the picture with trauma, and that's actually wrong. There are many other diseases. It could be cardiovascular disease, autoimmune diseases, and metabolic syndromes, and premature mortality also. And many people are, many of the patients, even that what I see in my practice also, are just, just pushing all these things away, and they feel, okay, this is a normalcy, and they feel, okay, we'll get over it, is what they say sometimes, right? So that is what we are seeing according to the latest research. So moving on to the next slide. Now, the brain's fear circuitry. I'll be getting a bit technical here, so I would want everybody to focus. So the brain's fear circuitry, the amygdala, hippocampus, uh, and the prefrontal cortex. Have mentioned the PFC. It is termed as prefrontal cortex itself. So and as I mentioned, the amygdala, it is the two almond shaped nuclei in the medial temporal lobe. Now this is the brain's primary uh, threat detecting system. Now this is where it receives sensory data, sensory input via two important neural pathways. We call it as the neurode when it comes to then in neuroscience. First it reaches the thalamus and then to the amygdala, less than 15 to 12 milliseconds. For more fast or unconscious threat assessment at the high road, what we say, or the high intensity level, the thalamus goes to the cortex and the cortex goes to the amygdala, less than or about 300 milliseconds. Now, that is more for a detailed and conscious processing of the data. So when we talk about in aspects of trauma, the amygdala becomes more hyperactive. It is started to getting sensitized, right? The firing responses to stimuli that merely resemble the original threat, that this is the neural basis of trauma triggers. We have something called as the BLA, the basolateral amygdala, another region of the amygdala itself, the basolateral part of it. Now, this encodes emotional memories. The central nuclei initiates this autonomic responses through the brainstem, right, or the hypothalamus, and the hypothalamus as well. Now, when we talk about trauma as or a classification of it, one thing is that it also depends on the intensity of it, the duration of it, the development and timing, and the interpersonal response and the nature of that particular event, right? So now what we can also see here is that the human brain is has evolved survival mechanisms that help us protect us during these threatening situations or traumatic situations. Now, these survival techniques and responses are very natural for us. It just comes very naturally, and but at the same time, it comes at a very rapid pace, and it is very automatic and very unconscious at the same time. Now, when the brain perceives danger, or when the brain perceives sensory information, now is that has been constantly and rapidly being processed by the amygdala. And as I mentioned, the 12 milliseconds, it is much faster than that, for all we know. So now the body, when it comes into this thing, the amygdala acts as an alarm system, wherein it is activating the autonomic nervous system. Right? So when this happens, this particular activation that is there, this leads to the classic that everyone that we have saying,
76 G5S.
yeah, I think we will resume. So now, since we all know what the fight or flight response is, it is wherein the body and the amygdala is just saying, okay, this is you have encountered a situation where you have two options: either you fight it or you flight, wherein you are to face the situation or just run away from it. Now, for anybody who has or is going through that particular event, it definitely does not look normal, and it does not look easy also. For us, it might say, okay, just run away from there. But for that person, for the person who's actually undergoing that particular incident or a stimulus, the body is just frozen. The person doesn't understand what to do, how to go about it, what to do next. They're just stuck, right? Because there's a lot of internal processing that's happening, and that is something very immediate, and that is something very rapid. That is something new for the body, and which is why the response is going to be being stuck. Now, in the in the fight response, the body prepares to kind of confront the entire threat through the increased muscle contraction. The muscular contraction is one of the things that we are been seeing, and also the most studied, researched upon topic that we have, especially the muscle contraction, and as to why it happens and what can be dealt with, how it can be helped with. That is something that is going on, and also the heightened alertness and the increased heart rate. Now, and there's good amount of release of adrenaline as well. So when all of these things happen, the body prepares to escape this particular danger. But the trauma responses are not only limited to fight or flight, right? Now, in situations like these, we understand that where escape or even resistance, sometimes it just becomes impossible. Now, the nervous system may activate freeze response, but during the freezing also, now some people may experience, sometimes sudden like immobility. Just can't move, as I mentioned about being stuck. And at one point, they might even experience dissociation also. And dissociation is, again, it is a more complex topic that is to be discussed upon, which we'll be discussing on the next time. So dissociation and is something that also takes place during this, and we become numb. And the emotional override that is also happening at the same time is very alarming for the rest of the brain regions, and all of the regions are just screaming and shouting what is going on, right? So we'll go back to the hippocampus. The hippocampus, as I mentioned, it is another brain region, which is mainly involved in the memory aspect. Also for the contextual memory, it tells the amygdala that the stimulus is safe or not, or how, what went on, what was the exact detail or the context of it, you know. So it encodes episodic memories with spatial and temporal tags, allowing the brain to, have a like having to distinguish between threats that you have been through from the past and safety in the future, that is to, what is to come, right? So for example, in PTSD, the hippocampus, we can see that in hippocampus there's a shrinkage, right? The shrinkage up to 8% of volume reduction in chronic PTSD. I have also attached a particular research study regarding the same. If anybody would like to go through that particular paper, I'll be more than happy to send you the papers. So now, because of the glucocorticoid and the neurotoxicity and the reduced neurogenesis, we can see significant amount of shrinking in the brain. And that is also because of the atrophy, right? So this atrophy impairs and disrupts the ability to contextualize trauma, memories, making them feel, very present, right? And some of the most important aspect of it, it could be flashbacks and hypervigilance. That is also a factor here. And there are many different fields, like but the regions in the hippocampus, that is the hippocampal CA1, CA2, CA3, CA4 fields, are, very particular, especially the CA1 and CA3 are more involved in the vulnerability to stress-induced damage. So we'll move on. Now, this is the prefrontal cortex. I'm sure many would have known about what prefrontal cortex is, and this was one of the most talked about topics also. So this particular part, wherein the the ventromedial prefrontal cortex, the VMPFC, and the prefrontal cortex, the dorsolateral, the dorsal lateral side of the prefrontal cortex are the most important parts here, especially for the top-down and bottom-up regulation and the understanding of spatial information. We have something called as visual spatial abilities. So we have something called as kinesthesia and synesthesia. Those are topics which I would love to talk about, but since we have a timeline which is uh, limiting me to talk about it, but if we'll get there next time. So the VMPFC kind of inhibits the amygdala firing through GABAergic interneurons. Now, this allows the rational context appropriate responses to be overridden with fear, right? So, as you can see, the fear circuit, it starts off with an input of sensory data. It could be sight, sound, or it could be smell also. Now, this could be any stimulus, right? And that goes into the thalamus, and then it goes to the low road to the high road, and then it comes down to the amygdala. There's a fear response that is taking place here, and then essentially reaching the hypothalamus, then leading to the HPA axis dysregulation. Now, this takes place when there is chronic induced stress responses of trauma or trauma responses or fear and anxiety also. Now, what happens here in the prefrontal cortex? The entire prefrontal cortex is aroused. Now, it is hyperactive. Even for that, at point of time, it doesn't know what exactly to do. That is why the entire decision making is disrupted. The, the prefrontal cortex is not able to take a particular decision. Should I run away from here or should I just face it? Because in the back end, the amygdala and the hippocampus are going absolutely crazy. They are firing left and right. But now, because of this, even the prefrontal cortex is definitely confused, right? So at one point of time, it starts inhibiting certain aspects of it, and then the amygdala goes down, and there's a lot of more processes that takes place after that. So in PTSD, now we have also seen that neuroimaging consistently shows there's good amount of reduced ventromedial prefrontal cortex activation and amygdala. Now this imbalance is also having a lot of importance on the neurobiological aspects of PTSD. Right now, this entire dysregulation explains why it is so difficult for us to concentrate and why we as individuals we would have a lot of emotional dysregulations for the same as well. Now, as I mentioned, like, there are a lot of neuromodulatory system that is involved here. It could be serotonin and norepinephrine. Now, these are very well influenced by the PFC amygdala communication. So, coming back to the HPA axis and why is it important? Right? So the HPA axis, as I mentioned recently, hypothalamic pituitary adrenal gland axis is the central stress response system. When there is a threat detected, it automatically gets activated. The hypothalamus releases corticotropin releasing hormone, that is ZRH, and then it goes to the anterior pituitary releases we call it as the ACTH, adrenocorticotropic releasing hormone. Now, the adrenal cortex then releases something called as cortisol. Now, this entire process takes less than half an hour, but has a lot of other prolonged effects that happens after that. Now, the maintenance of glucose, the immunosuppression, increased prefrontal cortex. For example, at that point of time, the amygdala is hyperaroused, the prefrontal cortex is hyperaroused, right? And the entire memory consolidation, retrieval, and encoding is also dysregulated. And the enhancement for the stressful event it becomes difficult. So why do we say cortisol is a double-edged sword? Right? Cortisol is very needed for survival, right? It raises the blood sugar in our brain. It reduces inflammation. It helps with consolidation of memories, especially fear memories, to help avoid future threats. But at the same time, chronic increased cortisol levels, that what we call as hypercortisolism, is toxic. that is definitely not okay for the brain and for the body, because now it starts to deplete, right? It starts damaging hippocampal neurons through glucocorticoid receptors and overactivation of it. Now, the inhibition that is taking place, we call this as the BDNF, the brain derived neurotrophic factors. Now, these are some of the most crucial parts, right? And it kind of disrupts the neurogenesis at the same time. So, looking at how PTSD patients show hypocorticolism, and and how it is chronically low cortisol due to the HPA axis being downregulated, and there's good amount of increased glucocorticoid sensitivity also. Now, this impaired system, this impaired cortisol response that is there, it fails to terminate the stress reaction, perpetuating the trauma cycle, right? So that is why we say that especially the cortisol is a double-edged sword. So I won't take too much time here in this particular slide, but I would want to mention it. We call it as the catecholamines, and with regard to epinephrine and norepinephrine. Now, I did talk about the HPA axis. This is the particular flowchart line. Hypothalamus, it releases CRH, then it goes to the pituitary gland, and that releases something, and then it goes to the adrenal gland cortex, that releases cortisol, and that targets different surrounding regions. It could be the immune system, it could be the metabolism, and the brain, right? So the negative feedback loop, sometimes it may be displayed as normal, but that may be completely disrupted in cases of PTSD, right? So the sympathetic nervous system, I'm sure everybody would have read about it, and the adrenal medulla release, the epinephrine, that is adrenaline. Now, it starts to take place within seconds of the threat being detected, right? Now, when this happens, right, it is activating the amygdala. Now, this is amplifying the emotional encoding of these memories. And that is why, which I had mentioned earlier, that the brain, the amygdala and the hippocampus work bidirectionally. Right now, the PFC's, the prefrontal cortex's functions are being reduced. It is being suppressed. Right now, that brings down the rationality of thoughts, or the decision making, what to do and what not to do, and whether to take a call or not. Right, and it activates the locus coeruleus of the brain's alarm system. So in PTSD, the noradrenergic system is always active. It's very chronically hyperactive. So high levels of neurogenic, NA levels explain why there are hyperarousal symptoms, right? There are sleeping disruptions that are happening, and there's always a heightened startled response for any of the stimuluses that they may encounter. Now we have something called as prozacin. It is the alpha-1 antagonist. It's a particular drug that blocks the NA and then reduces trauma nightmares and helps with better sleep. Okay, so we'll move on to the neural substrates of the survival response. Now, there are a lot of things that also takes place when we are exposed to a particular trauma response. Now, the fight or flight, which I already explained. So the neural pathways that are involved in this are the amygdala, and the PAG, that is the periaqueductal gray, and then the motor cortex. That from there it goes to the motor cortex activation. So the norepinephrine, it kind of enhances the muscle readiness, right, and the testosterone kind of moderates and takes over the aggression intensity also. So what happens physiologically, if you may ask? So physiologically, we can see the increase of heart rate. It is naturally more, and the BP starts to go up, and there's good amount of pupil dilation, muscle tension, the contraction of the muscular regions from the mucosal regions as well, and the blood flow to the upper extremities and the lower extremities also. So the cortisol kind of mobilizes glucose for the sustainability of the sustained effort of this particular response. Now, in the flight, what is happening in the flight response? The amygdala is being hyperactivated. Then it is going to the lateral hypothalamus, the lateral side of the hypothalamus. Then there's activating the SNS part of it. The suppression of the prefrontal cortex rational function. Now, the hippocampal input, it kind of tells us that it guides and it directs us to escape and to plan what to do next at that immediate moment. And that is also one of the reasons why we call it as the fight or flight response, especially the flight response. So the physiological responses are the high increase of the adrenaline, and the cardiac output is also increased here, and the bronchodilation inhibition of the digestive functions, the GIT, the gastrointestinal tract is also being affected, and the blood redirected to the muscles. Now, now, one of the things that we see wherein the freezing happens, as I had recently, like previously mentioned, that a person would suddenly freeze and would not know what to do and how to go about it. Right? The periaqueductal gray, which is also being involved here. Now, this is the one that is mediating the tonic immobility. Right? We call it as a dorsal vagal complex. Now, this activates parts of the, I'm sure everybody would have known or would know about the polyvagal theory. It's called the Porges polyvagal theory, where the endogenous opioid, the endorphins that are released, reduces the pain perception. Right? It kind of acts as a analgesic at this point of time. So in this aspect, the physiological response to this is going to be the parasympathetic dominance, heart rate dropping. Now the breathing slows down, the muscles become more rigid, they start contracting, or they suddenly become limp. Right? And there are times where the dissociation also takes place. Now the dissociation occurs as the cortex goes suddenly, switch off mode, right? It just suddenly goes offline. To to reduce suffering. It just doesn't want to continue with it. So that just leaves goes directly to the fawn stage, where the social engagement system is what we can see. The ventral vagal complex is being taken over by fear, right? So the amygdala activates appeasement behaviors through the prefrontal limbic systems, or the circuits. Now, the oxytocin systems may be dysregulated here as well. Now, the physiological response here is the appearance of being like calm, like the outwardly calm appearance, like where we would display ourselves, okay, I am calm, no, nothing is fine, like, sorry, nothing is wrong, I'm totally fine, I'm totally okay with this, there's nothing wrong with me. The social mask is what we can see here. And but internally, there's a lot of things that is happening outside, like from what we display is something else, and internally what is happening is something entirely different, right? There's a good amount of cortisol release, and there's a good amount of hypervigilance also. So the body performs the being calm, but at the same time the while the stress system remains activated constantly. So we'll move on to the next slide, which is the neuroinflammation and the epigenetics. Now we'll be looking at the trauma at the cellular. This may be a bit complicated. I'll just brush through the topics because I just don't want to spend too much of time here, because if I do, it'll take more than an hour. Okay. Now, as I had mentioned about atrophy, that that usually takes place when we talk about trauma or any kind of fear response, or PTSD also. A good amount of information that has taken place in the body, which is definitely not good. Right. And that is what we also say to our patients. Like I personally deal with the geriatric population with regards to dementia and Alzheimer's. And when we talk to our caregivers, when we tell that, okay, see, this is what you have to do, or this is what you should not do, many of them would not understand, right? Many of them would not pay more attention to it. But it is surprising that, even the inflammation in our body, if it is being consistent, and if it has been chronically there, if the stress has chronically been observed, then there are chances of one might be able to develop dementia also, for that matter. not just because a person would have issues with with trauma or something like that. One can ask, I just have issues with my trauma, or I just have PTSD, why am I prone to dementia or such neurodegenerative diseases? But that is also, there's a reason why there is something where the good amount of dysregulations at the cellular level that is taking place, and because of this there's atrophy that is being created, and because of that there are high chances whether the brain could start to shrink, right? So we'll just get into the neuroinflammation part. Now here, the trauma activates the immune system through the like different pathways. Now the stress-induced glucocorticoid resistance allows the pro-inflammatory uh, cytokines is what we have. Now that we call as the IL-6, IL-1 beta, TNF alpha, to kind of to propagate the unchecked processes, and it elevates the CRH and activates the mast cells and the microglia and the brain's resident immune cells. And that leads to the triggering of neuroinflammation. And also, most importantly, the gut microbiome dysregulation. Because of that, the gut flora is being disrupted. That leads to dysregulation completely, and that leads to inflammation through the gut brain axis. Now, that is something that is left unnoticed and unchecked by many. They would not even want to think about such things, right? So what is happening here is that my point is that we are though there's a good amount of inflammation, but there is trauma. We can see trauma and understand that from a very cellular and a molecular perspective. And because of this being such an important issue, uh since we all know that everything is all about cells, everything is about cells. If a cell is healthy and if it is working fine and everything, that's a good sign. Similar to cancer, what we can see is that cancer cells are not healthy. They are like an amalgamation of different unhealthy cells put into one. Now, the healthier the cell is, the better it is for the body. Now, chronically elevated inflammation damages the tissues, the neural tissues, and the impairment of the synaptic plasticity. We'll get into the neurogenesis and synaptic plasticity in the later part of it. And now that just leads to more like disorders such as depression or even cognitive impairment such as dementia and other comorbid conditions, such as it could be any cardiovascular disease or metabolic problems. Now people think that okay, this is all fine, like well said and done, but what has genetics has to do with this? Genetics has everything to do with it, right? What we call as epigenetic modifications of trauma. Now, it just doesn't change the cytoarchitecture of the brain. Like it just doesn't, reduce the hippocampal volumes or shrinking of the brain. Not, it is not just that, right? It changes how the genes are predisposed, genes are expressed, right? Some of the major mechanisms of the are the DNA methylation. Now, this chronic stress hypermethylates the NR3C1 gene, the glucocorticoid receptor, that promotes to the reducing of cortisol sensitivity. Now, this is primarily found in the both PTSD patients and and also the children of the Holocaust survivors. I have given a reference to that as well as of the paper. Now, is it true that, okay, there's definitely ongoing research regarding the same about how epigenetics and how it is embedded so deeply in our system. And that is why we can see trauma at a very cellular and a molecular level and at the DNA level as well. Right. So epigenetics changes can be transmitted to our offsprings as well. Right. Now the children's of Holocaust survivors showed that altered cortisol profiles and increased PTSD susceptibility of from the parents. Now, now, because of this, the methylation passed through different gametes as well. So this kind of makes the trauma a multi-generational public health crisis, but not just an individual psychological condition or a fear response. So, uh, how is trauma stored in the body's tissues, organs, and nervous system that is sometimes beyond the brain? Now, what we have to also understand is that when we talk about the neurotransmitters in our brain, right? Before we get into that, I would want to just talk about neurotransmitters, where there are chemical changes that are being taken place rapidly, right? Trauma significantly alters the entire neurotransmitter system that are within our brain, and the neurotransmitters are chemical messengers that regulate, it could be cognition, it could be mood, it could be arousal, and it could be emotional processing as well. Now, there's, which I mentioned, the norepinephrine. There's norepinephrine is there, serotonin is there, dopamine, GABA, glutamate, and many other. So when all these things are taking place, it could be norepinephrine, which activates the high alerted state, or which that leads to hypervigilance. Trauma survivors, they often show that, elevated norepinephrine activity that leads to hyperarousal, that leads to the subtle startled responses, and many others such as glutamate also. Glutamate, especially the excess release of glutamate, may have excitotoxicity for and neuronal damage as well. Now, when we talk about, as I mentioned previously, mentioned about the parasympathetic nervous system, there's a lot of damage that is happening at the cellular and the molecular level. That could be hyperalertness and dissociation. At the same time, when we talk about uh, childhood trauma and the brain development and how trauma is stored in the body's tissue, is where, see, okay, the childhood trauma is particularly been has seen effects because the developing brain is highly plastic in nature, right? So and is very sensitive to environmental experiences as well. So now any kind of abnormal or adverse experiences that we see, such as abuse, it could be sexual abuse or neglect, from the parents or anybody else, they meet it with others, and the parental conflict and emotional deprivation can kind of alter this entire synaptic pruning, right? And that has a problem, like at a very cellular level, that is the synapses level, and neural connectivity, the connectivity between the neurons and the attachment circuits. Now that has a, at a long term stage, the attachment circuitry becomes a problem. Not everybody would be able to grasp this topic in the very beginning of their trauma exposure, but later on, as they go on, as they grow up and everything, it definitely becomes a confusion for them. So children who have been exposed to chronic trauma or the fear response, they can definitely develop something called as hypervigilance, as we discussed, and a lot of emotional dysregulation from time to time, and the executive functioning is completely impaired, right? It's get dysregulated completely, and there are chances where a child would have difficulty in learning things, and difficulty in even grasping the basic or the basic things, and that also has attachment disturbances as well. Now, when we see the muscular tension, we this concept is where we call it the Reish concept of armor, where the muscle tension, uh, I know, as this frozen emotional defense. Now, this diaphragm, it be the muscular region in the jaw, the masseter, and the shoulders are the primary tension holders. The body's impulse to fight or flee that particular response was suppressed during trauma and remains a chronic muscular activation. Right? There's something called as TRE, the tension and trauma releasing exercises. Now, this uses the neurogenic tremors to discharge this tension that has been stored, right? And the myofascial restriction patterns, such as fibromyalgia and chronic pain syndromes, are very common with the trauma, the entire sequences. Now, the interoception of the brain, right? Now, this is also something where is completely altered. Now, the brain's sensing us, like the internal body states is definitely affected by trauma. It is altered by trauma. It is dysregulated by it. And the insular cortex is another region that we have in our brain. Now, that shows abnormal activation in patients who have PTSD, right? So that just gives us answers as to why there are hypersensitivity that would be like numbing and complete disconnection from the body. Trauma survivors, like sometimes they often cannot accurately sense what is what. Sometimes they are like, okay, am I feeling hungry? Am I feeling, is it thirsty for me? Am I feeling thirsty? Is this pain or what? Right? They cannot differentiate between things. Sometimes you are sexual arousal, the body signals are very drained out by that particular system. Now this entire disruption has disorient, like, it starts disorienting a lot of other processes that takes place in the brain. So the immune system, how is that here, right? How is immune system and the autonomic processes here involved? Because something that is happening to my brain, why is it going to my immune system and the GI tract? Now the activation of the chronic SNS, this elevates the resting heart rate and it also the BP, and the inflammatory process also is being taken place that leads to a cardiovascular disease, and that risk is just being taken up high and high and high, especially in patients with PTSD. So the vagus nerves anti-inflammatory reflexes is definitely impaired here, right? So the gut brain axis is especially the one that is to be affected. Now stress or a chronic release of cortisol alters the gut motility, right? The microbiome composition, the intestinal permeability is what we call the leaky gut sometimes. Uh, Having this a bidirectional inflammation feedback loop between the gut and brain. And that is also how the trauma is affecting the immune system and the gut brain axis as well. So when we talk about how one would experience trauma and how to deal with trauma, it is definitely not easy. Again, everybody has their own experiences. Everyone would experience trauma at different stages of life and different ways. One can say, no, this is something else and this is something easy for me. You have experienced trauma, something, in a different way. But trauma is the same, but the how we perceive and how we come out of it is definitely a thing. Now, what we understand is that what are we supposed to do when we there is a need for help, but is the patient ready to talk? Is someone who has been under trauma or someone who has been under severe stress, are they willing to let it out? Right? That is why we call it as the speechless horror, wherein patients don't want to talk about. It could be anything. It could be even about a particular traffic incident. If it is too traumatic, they would not want to talk about it, right? And now one of the findings that we saw is that wherein the white spot of the left frontal lobe of the cortex in a region called the Broca's area, right? Now, that is why I spoke about the speechless horror, wherein in the case, this change in color meant that there was a significant decrease in that part of the brain. So all trauma that we see is definitely pre-verbal, right? And can overlap with the effects of psychological lesions like strokes, for that matter. So like years later, traumatized people have usually have enormous difficulty telling other people that what has happened to him or what had happened, for that matter. So their bodies kind of experience terror, rage, helplessness, as well as the impulse to flight or flee. But but these feelings are almost impossible. Like these almost impossible to articulate by anybody who has undergone trauma. So trauma by nature drives us to the edge of comprehension, cutting us off from the language-based common experience or or an imaginable past. But that doesn't mean that people can't talk about a particular tragedy, or that has befallen them. But sooner or later, most survivors that we have seen, even though is people who I have also seen. Uh, Sometimes when I talk to my students, also we discuss about when we discuss about trauma, we always discuss about the wars that the soldiers have been through, and that they are always there, and the kind of trauma that they have perceived, right? Especially the veterans. Now they come up with many of them called the cover story that they have they use as a cover up, right? They give us some kind of explanation to us for their symptoms and the behavior for the public consumption. But these stories, however, sometimes they rarely capture the inner truth of our experience, of the experience that they had to deal. Now, that is something that is extremely, difficult to organize one's traumatic experience in a very coherent perspective or a way, right? So, when that happens, there's the narrative that has been taking place. A narrative with a beginning, right? A beginning, a middle, and then an end. So, like, when words fail sometimes, uh, when the person is not able to say anything about it, the haunting images or flashbacks that keeps coming, that the hippocampus just keeps firing left and right about that particular event, at that point of time, the the deactivation of Broca's area has been seen. There have been research studies which definitely point these out, especially the broadband area 19, if I'm not wrong, is being lit up. That is what research has also been observing. So this is a region in the visual cortex that registers images when they first enter the brain. Now, there is auditory memory and there's visual memory as well. That is why sometimes where we hear a particular noise, and if that we feel that okay, this is traumatic for me, or if you have dealt with something traumatic, we are naturally startled. We are naturally more alarmed and awake, and there's a lot of other processes that immediately start to take place. But you know, this is where the first entry starts to take place. And to be honest, we were surprised to see that the brain activation in this region, in this particular area, is so long after the original experience of the trauma, right? Under ordinary conditions, raw images registered in the Broadband serial 19 were rapidly diffused to the other brain areas as well. Now, once again, we start to see the brain region kind of rekindled as if the trauma were actually reoccurring. Now, because of this, that is why therapists and psychologists and clinical psychologists take a lot of time as to understand their perception of trauma, understand what trauma is according to them, what they feel about trauma, and how are they dealing with trauma, and what could be done, right, to get them out of this, and kind of give them a kind of a guidance as to how they can reach a safer ground. And because what we can see from time to time is that there are a lot of patients who are constantly in trouble, or not trouble, I'd say, but constantly in the fear of panic, and this alarmed state of mind, the hyper arousal that we can see. But that definitely is something that is not okay for them, and it's not like they enjoy it as well, but they would want to come out of this. They definitely would want to, but they would require a lot of help. So that is why we start, there are multiple like modalities when it comes to therapy. The CBT, DBT, RABT, like there are so many things, but a therapist would assess the patient first, and moreover from there on would like to see how the patient is able to handle things, handle therapy, or first we would check the level of insight. How much does this patient know about himself or herself, and can we work around that particular matter? So that is the primary thing that we would see. But given that, pharmacological interventions are definitely required here. I would definitely recommend it, though we all know about the side effects. But uh, during therapy, there is a reason why psychiatrists often, prescribe certain medications. It could be escitalopram. If one could have sleeping issues, benzos would be used to relax the muscular regions. I would not say using the usage of sedatives, but so something called as Zolfresh, right? Zolpidem. This helps with sleep. Now, sleep is a very important aspect as well. So, with chronic or acute trauma patients or patients or PTSD survivors, sleep is also a pattern or like a thing which is constantly being disrupted from time to time. And usually, when we talk to people, when we ask like how many hours did you sleep, one would say, "Oh, yeah, I slept for around like 5 to 6 hours, and I'm okay. I'm okay. I'm happy. I'm emotionally well oriented and everything." But they don't know what is going on internally. Uh, What I will be saying right now might sound very stupid or might sound very silly, but in our department of neurology, on neuroscience, it is always advised that a person should sleep max to 7 to 8 hours, at least please aim for 8 hours. It is really good for your brain and the body. It could be in terms of neurogenesis, neuroplasticity, so synaptogenesis and synaptoplasticity. All of these things are very essential for our body, right? There's when there is less when there is less amount of stress, that can lead to more neurogenesis in the sense new healthy birth of new neurons, right? And that is good. And when that has been taking place, parallelly, the drugs are working out, and at the same time, therapy also kind of works out. So all of when all of these things are done at a very like in a circle, then can we see like good outcome of the patient, and then the prognosis becomes better, is what we can see and understand. So before I close with the session, I would like to point out that whoever has gone through trauma such as these, who has gone through it and would not want to speak about it, I understand it is not easy as well, but we have to start somewhere, right? We have to start somewhere to come out of this and to heal. We have to start healing. We have to start the healing process, to heal ourselves regarding the same. And at any point of time you would require such things, please talk to your immediate friends and family regarding the same. But regarding your issues, sure, but if you would want professional guidance or therapy, I would strongly recommend you to always go talk to a therapist or a psychologist, because they are the ones who are going to be guiding you on that matter. They'll be telling you how to go ahead with it, because they are the more experienced ones when it comes to the human brain and behavior. So that is what I would say. So yeah, that is that. Thank you for everybody who has been on the uh, you know on the session for the past 1 hour, and it'll be nice if if anybody has any questions. Shreya.
Yes, sir. Right, so the floor is open for questions. If anyone wants to add any question, they can in the chat box. And thank you so much, sir, for this wonderful session. I think you really went into the depth of understanding how our brain works in traumatic experiences, even after and before. And I believe that most of us, at least I have gotten a very in deep understanding of how it goes through. So thank you so much for this wonderful session. Before that, sir, would you like to present your screen to show a little
Yes,
about positivity?
yes. Do that. And does anybody have any questions regarding the same? I would be more than happy to answer them. Okay. So I'll be sharing my screen again. Uh, Right. I hope everybody can see my screen. And so this is my profile. And if anybody would have any kind of issues regarding the same, uh, please feel free to take a consultation with me. Uh, it could be half an hour, it could be an hour, or more than that. I'm available most of the days, especially during in the evenings. So, what I majorly deal with is neurological rehabilitation or neuropsychological rehabilitation, but I also deal with CBT, ACT, behavioral therapy, existential therapy, and the major some of the disorders that I deal with is going to be depression, mood disorders, ADHD, and behavioral management, and adolescents, and geriatric plus pediatric uh, population is what I also see. So if anybody would have any concerns regarding the same, I would let you know that please feel free to take a consultation for the same, and we can see what we can do.
Thank you, sir. Thank you so much. And yes, sir is listed on us with Positivity platform. So you can go to the website positivity.com and see sir's profile and also different profiles of psychologists who you want to probably, go ahead with. So thank you so much, sir, and thank you everyone for joining. Thank you.
Thank you, Shreya. Thank you, everybody. It was a lovely time with you guys, and hope to see you.